Okay. So welcome back, folks. First off, does anybody have any questions about what their assignments were? Or are? Okay. Second, I realize I hadn't asked anybody to do 248, and I'm just wondering, Esme, if you'd be willing to report 248.
Oh,
Think about it if you want to think about it. I don't want to put you on, I mean, I realize I'm putting you on the spot. But,
36, I'll do
Step up.
it's not that simple, little straightforward bill, right?
so,
You signed on
Think
too
about it.
early,
Yeah.
that was a problem.
It's a good one. I'm voting for it, so it's a good one.
All
Okay. That's one to do because I don't have any.
okay. All righty. So, let's take a look. And I do have to do a shout out to Eric. You know, I don't want to embarrass him or anything, but Eric says, well, when are we going to do these reports? And I'm like, I hadn't even contacted him with his assignment because I gave out the assignments and he had already gone back and listened to our testimony and already had them out. So you get extra points, Eric.
Yeah, boy.
I'm just saying. You're just like, Mr. Prepared.
I know. Yeah, fully prepared.
Oh,
Thank you.
was he here when he found out about the Star Wars skit?
Yeah, we don't need to do that on live.
Oh, I forget we're live.
Yeah. So do you have any reflections on your reports or
Not
should we
yet.
save that? Okay, that's okay. I'm just was double checking because I know that you're going to be in and out a bit. So I'm just going to ask now, maybe this will be a short meeting. Has anybody done theirs
I
yet?
have one.
I
Okay,
have one of them.
I also have one.
okay, all right. Let's start with Zon.
Okay, the one that I'm looking at is the next to last one on the list, Vermont Ethics Network. It's about the 25 annual report of palliative care and plan management task force. It was a 13-page report, and I'm going to summarize it this way, and some if I'm doing on the right track or not. Basically their reporting, their work is to convene organizations to keep top of mind end of life decisions and end of life care services. They are grateful for the overlook of the legislature, and they talked in the report about some information, some of the past. I guess this report's been needed, requested since 2009. And they have no policy recommendations as the overall group for going forward for this year. So they're just basically giving a report. So what I'll just summarize it as they have 10, they characterized 10 events they ran statewide. I guess it's actually 8. 8. 4 were they could speak about because they were prior to the report, and 4 they were planning since the report appeared. Before the report, they struck me as being healthy attendance. There was about 150 or more people at each of the events that they had on the various subjects that they touched. So I thought that was impressive. And then they just characterized the work of 7 organizations that's part of this network. That's the Ethics Network itself, Central Vermont Home Health and Hospice, DEVA, Patient Choices of Vermont, Pediatric Palliative Care Program, UVM, which has a number of different elements and programs under it, and then the Visiting Nurse and Hospice of Vermont and New Hampshire. They talk about that each one gives a little bit of detail about where they are right now. And then finally, they just are again express their gratitude, and they hope that the legislature will hold palliative care issues and end of life decision making issues high on our list of care and consideration. They're very interested in collaboration, and they note that there's robust energy around this across the state. That's what I would say.
Did they make any recommendations about the need to continue the report?
No, I didn't. It seems as if when I read through it, each organization also had a moment at which they could suggest some things, and no one had any. Their challenges. They did mention challenges, but they're sort of specific to the organizations. And no, I don't think that they. I didn't see anything that said that they would prefer not to be doing this any longer. It's a good list of partners too that prepared the report. So
So the last thing that we did around, in this topic was the what they call it MAID, or medical aid in dying, and it was to remove the residency requirement. There were some lawsuits pending about that, and we sort of preempted the lawsuits because they had been decided favorably in other jurisdictions. So we acted on that, and I'm just wondering if people would be interested in having me in to see if what did they discuss that at all in the report?
yes, they did. They also talk a little bit about that was under the care of Patient Choices of Vermont, and they speak about the activity on their website, which they have. They could attest to 90,000 views of a video that they've created about this work. So there's a lot of interest in just learning, I think. And then they do talk. They're the ones that talk about access to MAID. So let me see if there's anything that they say. It's that they're not able to provide any real data. It's impossible, they say, to determine who actually saw the information. So or used
In terms of
in state or out of state.
Yeah.
Yeah. So
yeah.
So I'm curious, because I assume there's one of the sub-reports would have been the advanced directives use. Our rate was incredibly low, and our people who died in hospitals, even though the majority won't die at home, was very reversed. And I was wondering if they had anything about a change in that trend.
I didn't read anything like that. Advanced directive, who operates that program?
Well, that's the Vermont Ethics Network. That's why I jumped to the conclusion that it would have been in part of that report, but maybe they don't. I mean, it's kind of part of not palliative care.
They did upload to the registry about,
There were the last time we talked about that, I think it was before you rejoined committee, and there actually had been some changes to the process and to the documents that they give to people. So I'm as we go through this, I'm making notes of because we're going to have some time where we're not going to be working on bills as the month of May progresses, and where we can invite some folks in to give us some updates about some of these things. And so I made note to invite Cindy Brucese and Betsy Walkerman in. Cindy is the Vermont Ethics Network, and then Betsy Walkerman is Patient Choices Vermont. So she could talk to us a little bit more about the medical aid in dying and any changes that they have seen. I know that I had heard from colleagues here, representatives in Southern Vermont, that they had seen an uptick in the number of people seeking information and services in Southern Vermont, people from Southern or, other parts of New England, more south. Well, I guess everybody would be more south than us except for Maine. So I'll make note to extend an invitation to this.
I do see numbers here now. I'm sorry. I do see numbers related to that, but they're not related to prior numbers. They just said 55,000 people registered right now, but I don't know I don't know what number been before, so I don't know.
Yeah, I made a look on my numbers if I missed something about changing the provider, because I know I always was sort of impressed that you got an annual letter from the registry saying, do you need any updates, whatever. And I have not gotten one in some years. So that seems to have stopped. So
I got mine.
you got yours.
Yeah.
All right. Yeah, right.
I was just gonna say, related to the medical aid in dying, I reported that bill and it had some press coverage. So, interestingly enough, I had a lot of people reach out to me from outside Vermont because I was actually quoted in the New York Times.
Yeah,
Which is
there you
cool,
go.
because of that bill. But I'd be curious, because some people that reached out to me from out of state said that they had a really hard time accessing it here and knowing who to go to. And this is now a couple years old, but I remember when I reached out to the organization, they said that they didn't really have the infrastructure really at the time to help folks connect them to the right doctors. And we didn't have enough doctors that would be willing to do it here. So I would be curious if they came in to kind of hear more about like, how has the law, what have they done to kind of prepare for receiving other out-of-state folks coming into state and making use of the change that we made on the law here? And is the access a problem from their standpoint?
And I'm remembering now, it was from the home health and hospice folks in southeastern Vermont is where we had heard, you know, they had asked.
Well, I can
about
attest to that there was a real shutdown for VNH in southeastern Vermont just has stopped functioning. It used to be there, but because when it got taken over by Dartmouth, then a whole slew of communities in the southeast corner of the state have no access to service anymore.
Really?
Oh,
I didn't know it got taken over by Dartmouth.
Yeah.
Kind
I think so. That's
of like the Chittenden County one.
got taken over by,
Yeah.
well, so it's interesting for me, you know, reading this, not knowing, I don't have background the way you
Yeah.
guys do. So it's great to hear these questions. I can literally look at this now and see all sorts of questions I'd want to be asking.
Yeah.
So.
So we'll, I'll work on scheduling them for, sometime, in the next couple of weeks to see if they're available. And I think it would be good to get an update on the medical aid in dying and any potential changes that, if they've made any, recent changes in the advanced directive stuff. As
yeah,
well.
and as part of that, you know, are we seeing, I mean, the real key thing is the number of people I think the Ethics Network has that data, or did in the past, the number
So
of
you're
people
that.
dying in hospitals versus the percentage of people who say they want to die at home, which was, you know, it'd be good to see if that was starting to change.
Well, and part of, I think the reason that there was this annual report was, it had, something to do with the fact that Vermont was in the lowest tier of states in terms of utilizing the hospice, benefit
Yeah.
under Medicare. And we still are actually, I think, pretty low, and, that hospice is, very short in Vermont as compared to the length of time that it could be, where people could be assisted with.
Which again
Comfort.
connects to, they're
Yeah.
not making use of it to be able to stay at home and.
So I'll check with Jill Olson represents the, VNAs, and, Cindy and Betsy Walkerman. And so, thank you, Zon.
All right.
Appreciate it.
Enough?
Yeah, perfect.
Great.
Okay, Ann, you want to go next?
Sure. So the one that I had ready that I looked at was the medical cannabis report. That is that was a one-time response to a legislative request. And it was a really good reminder because it was something that last year I was really concerned and thought we ought to pursue, and then, you know, out of sight, out of mind. So if people who were here last year remember, there was some disarray of the medical marijuana, formerly known as use of marijuana for symptom relief, but medical cannabis, because of the much more easy access to, legal personal use. And so there were things that were done to try to help support the medical side, including allowing regular stores to get a certification. But as part of that, there were several, I'm sure not a lot of that is in place, has happened yet, but part of that was to look at was a request for a report on curriculum and education for physicians, for healthcare professionals on cannabis use, and potential mandatory educational requirements for employees that interact with medical registry patients. And several ideas did come up. There were also members of the work group who kind of filed reports disagreeing with some of the recommendations. One of them had to do with this Canify.us license you can get, where it's an app that people can look at their symptoms and sort of get recommendations. And I think the Medical Society didn't think that was a great idea, but and there was a question about how much it would cost. And medical education for providers, apparently one exists at UVM, and so that seemed to be in conflict. But to me, the one of real interest is the issue of how conditions get included as validating someone being eligible to get a medical cannabis card. And, you know, in a lot of states, they have a specific board established either under the Department of Health or wherever that assesses and looks at where there's some evidence base or whatever you call it. There's no real research because the federal government doesn't allow research. So we're in a little bit of a conflict there. How do you do it based on good evidence when you're not allowed to develop the evidence? But we are a state that has done it sort of case by case when some group or some subset of folks say, you know, our diagnosis is something where belief is, you know, really valid, and please add us to the list. And that's not an efficient use of our time, and it also makes it really haphazard. And I know, you know, last year as an example, we had a legislator who had a very specific condition, and you know, who was asking that be added, and it was added, but that's not the way that you should be going about. It was a valid example, but that's not a good comprehensive way of going about it. The very original set of diagnosis came about as a result of the committee sitting in this room, creating the first law, establishing the registry and so forth in Vermont. And it was kind of like everyone's vote was needed to get enough votes to pass the bill. So everyone had an individual veto power over a condition that could be on the list because to hold on to their vote. So I will always remember those little tidbits of memories because Val Vincent was on the committee and she absolutely did not think glaucoma should be on the list. So glaucoma did not make it on the list. It was that kind of a, because each person's vote was critical to getting enough to pass the bill through. And later it was added. But that was a recommendation that I think is something that ought to be taken up and looked at before the next request comes in for a specific, instead of being reactive and saying, okay, now we have to on the spot think about, should we create a different system versus saying, this is really clearly ought to be better coordinated and have better basis for doing it. There are some states, according to the report, that simply turn it over to the provider's determination that this would be beneficial for the patient and therefore sort of certifies the patient regardless of what the diagnosis might be. And a lot of states that have some sort of a board that has control of that. So
what it's seeming in looking through some of this, I mean, the recommendation that's particular to this committee is about the
this
process for evaluating and approving new qualifying
Right.
conditions, right?
Exactly.
And so the specific recommendation I'm seeing here is, well, they give us some options.
Right. Those are the, yeah.
Yeah. And so, I think that this warrants further, some further action, because I agree before we get the next request to add a particular
Mhm.
condition. And to be fair, we had some discussion in this committee about like, why do we have this anymore? Since there is a, it's not illegal in Vermont to have personal possession. And one of the main reasons, honestly, was because you can get this, because it is of what it's considered, it's not taxed.
There's also
And you can get
higher,
different,
higher potencies.
higher potencies.
And it is the only way that someone under the age of 21, including young children who,
Yes.
there's some specific conditions with the caregiver where it's appropriate. And, they would have no access at all except through this.
And seeing in this report, which I was actually still 2,700 patients as of the end of November registered under that. So I mean, it has decreased over time. There's a sharp increase, and then when we decriminalized it, it's taken a bit of a dive, but it's still quite a few people.
There are 11 states that do it by qualifying provider discretion and 12 that have a review process.
Oh, that's just what I was gonna ask.
Yeah, so the qualifying provider discretion would probably require more work on our statute to change, because we have a sort of unique process that prevents physicians from having to potentially endanger their license, because they don't prescribe or recommend it to their patients. They validate that the patient has the condition that the statute says they're eligible. And then the patient, based on that validation of the condition, is authorized to apply.
To enter the register.
To enter the register.
apply.
To apply to the registry, or you pay the fee or whatever. It's
So
not.
there's not another decision
There's
made.
there's no approval process. It's just a matchup. Okay, or is that on the
see.
statute? Did the doctor say they have that? But it's different for the doctor saying you have that condition versus saying, I recommend that
Right.
this condition be covered for
Right.
you.
So that's where we step in, because we discern the qualifying conditions.
We create the list saying, these are things that if your doctor says you have it, you're eligible.
I see, okay.
So, so it will require a bigger change in how we approach it to make it purely, provider discretion.
Okay.
But
So
they have a lot of different examples. Some of them have it through their Cannabis Regulatory Commission. Some of them have it through their Department of Health and so forth.
So, part of this is helpful because it helps us sort of like tee up some of the things that we really actually should be looking at that we haven't seen on our board yet. And this would be one of them. So I think we'll extend an invitation to James Pepper, who is the director of the Cannabis Control Board, and just have a dialogue with him around what we might think about for next steps around this.
Joe decided not to run again, but he and I were going to work on a draft bill last summer. But and we,
Yeah.
he didn't run, and it dropped off my radar.
Well, you had that little thing like a broken leg and.
Oh, yeah, that too.
Although that
Years later.
But that-
radar got occluded.
Right, that theoretically gave you all sorts of time, right?
Exactly.
Okay, so, thank you. I appreciated, I had a chance to skim through their report, and it's actually pretty succinct, which is,
Yes,
I love succinct reports.
yes. Well, it's 56 pages.
Well, it is,
But
the
that's because of all the
basic
appendices of all of the
Yeah.
commenting groups.
Yeah.
The report itself is
The
much.
report itself is much
Yeah.
shorter, yeah. Ray,
Yeah, so I reviewed the one-time report on the special accommodations grants that was part of Act 76. And the impetus for this was that we heard when we were crafting Act 76, we heard from a lot of providers and families that there's a lot of challenges to support kids in childcare that have special needs. And, the division has had these special accommodation grants for a long time, but they were very clunky and difficult to apply for. And, the terms were not very long, so providers had to do a lot of paperwork and the administrative burden was really high. So we included a provision in the bill that requested them to come back with some improvements and report on what they did. So they submitted a report last September. It was due in July, but they were a little late in this case. But good news is they've made a lot of improvements. You know, I think a lot of this work, Act 76, in theory, the investments in Act 76 are going to help with this problem of kids with special needs not getting the support that they need, because additional investment always helps providers get the resources that they need to help those kids, right? They need training, they need additional staff, they need special equipment sometimes, and additional investment. So this was kind of like, what can you do now until all this other work kind of catches up? We're still not going to fully meet it, but there's going to be a lot more resources available as a result of Act 76. So some of the things that they have done in 2024 as a result of Act 76 to improve the existing infrastructure was they extended the grant duration. So I think they went from a 6-month period to now they're annual. So programs can apply annually and be sure that they have the funds for the whole year. And then they also have possibility to extend those grants. So that provides for more consistent support for the kids and the childcare providers. They since COVID, they have been able to allocate additional funding to these grants. So these have historically been funded around $300,000. So as long as that can happen with the division, that's how much we allocated for these. So because with COVID funding, I think at some point we were all the way up to 800,000. And when that ran out, we supplemented, I keep saying we, the other half. They supplemented some of the funding and were able to get $600,000 as a result of the preschool development grant that they received. Important to note that that grant is ending. And it is very unlikely that there'll be future funding opportunities under the current administration for that work. So this is an area we're going to want to watch and see, you know, what the need has been. This report is from 2024. So my gut and my experience tells me that consistently they're receiving more applications and they have resources. So there's going to be a gap here if the division has to be forced to go back to that 300,000. So that's something for us to keep an eye on. And the increased funding has also allowed, to give bigger grants to programs depending on their needs. So in the previous iteration of the $300,000 in funding, they were only able to give very small grants to multiple programs, and now they can give larger grants to meet the needs.
My question is, there isn't anything because this is part of childcare.
Yes.
There isn't anything prohibiting the use of childcare funds from assisting the integration of children with particular needs in childcare.
Yeah, so
there should be the ability, they shouldn't, I guess, even after the grant funds, first they were using ARPA and then they were using, childcare development grant, but they should be able to use base fund. They should be able to increase the base funding with what we know is available funding in childcare. So
yeah, absolutely. And I think one thing to kind of keep an eye on, which I'm curious about, is I think the thesis for the department has been that as we increase support for programs and they have other resources such as the quality capacity improvement funds, the bonuses that they've received, the readiness payments, the need for special accommodation grants should decrease, right? I mean, that's what you want. The increased
Right.
investment should help programs feel that they have the support that they need across the board and not need these very special grants that are burdensome. So I think this is something that the division is studying. They have regular, they have kind of a task force on these and have two different teams working on it, the CIS team and the systems team, which is my team.
Mhm.
But so that's something, if they're seeing the need is going up, we need to figure out, do we fix it by special accommodation grants, or do we just support programs with giving them the resources that they need to become specialized care providers, for example? Because, and one of the examples is what the division is doing for, with the quality and capacity incentive program, there's a $10 million annually that they get, that they have flexibility of how to use that money. And they're using that to incentivize financially programs that will get their specialized childcare certification. So they, you have to meet the certain criteria, and programs that get that certification will get an bonus every time, an annual bonus, because you're getting that. So the goal is to increase the number of programs that are able to care for kids that have specialized needs. So we won't need to do these one-off grants to the various programs.
Not that I would want to replicate anything in the education funding formula. But, one of the things to maybe think about is a more systemic way to approach funding for children with additional needs, as opposed to this kind of like one-off grant kind
Yeah.
of thing. Do you know what I mean?
I think that's kind of the increasing the number of programs that have specialized care status
Mhm.
is a way of getting
Of
at
getting
that
at
right
that,
now,
yeah.
because the more programs that have that, you won't have that program applying for a SAG
Right.
if they have, because they get a higher reimbursement rate.
They shouldn't be applying for a SAG.
Right.
Let's just put it that way.
Right, so they, by getting that status, they get a higher reimbursement rate, which will help them get the support and the infrastructure that they need.
Mhm.
So, that program just went into effect in October, so we're not gonna have data
Right, for a while.
for a little while to see.
I guess the thing that that's reliant on a program's desire to apply, really.
For the
And
specialized
Yeah.
care status.
yeah, and so how do we then, I mean, from a systemic point of view, if we're thinking about all children should have access to quality childcare, then it shouldn't be dependent on an individual program's desire or not to apply. Do you know what I'm getting at?
Yeah.
Trying to think about this from a next level up, the systemic view of how do we assure, just like we want to do in education, how do we assure every child has access to appropriate education? And in this case, just one step
Early
down,
childhood,
early
yeah.
childhood.
I will say that the division has been working with sister divisions and departments, with DMH, Department of Health, around with BBF, around the whole idea of inclusion, more from a systemic. This report was very focused on the specialized accommodation grants.
Yeah.
But there are a lot of initiatives with AOE, UPK and in those settings. So they've been doing a lot of work. So again, as far as like getting further information,
Yeah.
that's something be interesting to have the department come in and tell us, like, outside this of the specialized accommodation grants, what are they doing for a systemic approach to ensuring all kids, regardless of the needs that they have, are getting the early education that they need?
Yeah, and they have some really good information in here as well,
Yeah.
in terms of, and we don't know, it makes me think about if the federal administration holds true and eliminates funding for Head Start, that is going to be a problem for a lot of families, and how would that coincide with what we you know, how we think about this, you know what I mean? So, all right, thank you.
Can I ask a question?
Sure.
I have, for my report, I have, the cosmetic. Who has Act 31? They're combined, they're a piece of each other. Who was assigned Act 31? I started doing mine and then had to refer back to the Act 31 report, which somebody else must have.
Let me see which,
Let me look. I wrote myself notes. Let me look. So whoever has Act 31, mine goes with it.
Act 131.
131, sorry.
Act 131, we've already heard, so I did not assign that to anybody.
Okay, well, mine is just
You
like
can review, the Act 131 report.
intertwine them.
It's because it's right on the webpage.
Yeah, no, I know.
Yeah.
I didn't know if somebody had it.
No,
That's all.
no, we did not assign it because when we heard the PFAS earlier in the session, remember the PFAS bill came here? We did a review of the Act
Okay.
131
Well,
report.
mine's goes with that.
Gotcha.
So, okay, good.
Okay, thank
So
you.
I'll just use that for,
Okay.
thanks.
Alrighty, so you heard three good examples of you know, what to
Good job.
expect.
2 out of 3.
2 out of 3. It was so yeah.
Failed this committee once again.
I did a good job.
You did. You started us off. And it's really helpful because one, people will see that we are actually taking a look at the reports that are due to the committee.
Mhm.
And two, we're gonna follow up on, I've got 3 different things to follow up on and, one from each one of the reports. So, I think that's good.
And Madam Chair,
Yeah.
I will say for other committee members, we are setting an example for other committee members.
I know.
Shared with
With other committees.
with vice chairs today, and I was like, that's a great idea.
Once again, human services.
I actually suggested us doing that in a past committee and people thought it was a good idea, but it never happened. So
Okay.
this is really happening. It's wonderful.
Is good. Okay, this is a public service announcement. If you plan to do any traveling, make sure you have proper documentation because you're requiring to have that little star on your
Yeah, I
license.
checked one just to make sure.
To fly.
In 2
yeah.
weeks to
To fly.
fly, if you're gonna fly.
Up in the.
I wrote myself a note because I'm going to fly in June and I'm
Yeah.
like, I don't think I have that.
You don't have
I think my passport is expired. We're done.